then I'll ask Bhaskar to come and talk about the ZAP and analyst trial.
uh, many of you, when again the same thing as Rajul, probably I'll go to the last two slides, which is a bit of an update. But let me finish it off. So, critical review of ZAP and analyst trials for role of iridotomy in PACS. So, topic is very specific, even though there are other publications on these two trials. I will just stick to the iridotomy part. So, this is like the twin cities, the twin trials of this thing. But the good thing that went together and then got published and the evidence gathered to support the WGC consensus. So, we are talking about asymptomatic PACS. That is something which we have to be, very specific. These trials dealt with asymptomatic PACS. We removed those symptomatic PACS from these trials actually. And basically, this patient who has just the angle closure and nothing else, how will we manage? In the past, probably pilocarpine was used, laser PI was done for every patient who was coming, and bilateral phaco, of course, with the eagle, people are very eager to do it. And of course, observation is not done at all. Observation is another option. So currently, these laser PI and observation is there. And prophylactic PI for PACS, WGC consensus, we know about it. The reason to do it is to prevent pupillary block and prevent progression. Possible adverse outcomes of laser PI must be considered, like visual symptoms, corneal damage, and cataract. And that is one of the reasons why the study was conducted. And of course, the massive numbers that is going to come when we are screening, even for opportunistic screening. So how do you counsel this patient, risk versus benefit? What is the risk of observation? And at that time, this was the only, I think they did a evidence-based update with the AO, ophthalmology. So LPI is recommended in APAC and fellow eyes at that time before the trial started. PAC and insufficient effect of LPI. So these are difference in the aggression of the disease. In the North Han Chinese did not have that much aggressive acute angle closures. That will answer your question actually before, that some of these patients had why Singapore had higher incidence of symptomatic and PACs as well. So the primary outcome in ZAP trial was IOP more than 24 millimeters of mercury, and peripheral anterior synechiae at least 1 clock hour. So that is something slightly different as well from our definitions in India, where any PAS is considered. That is actually in Velurai study also, that's the case. An episode of acute angle closure also is considered as thing, and of course development of glaucoma, optic neuropathy was also considered. The primary outcomes were that more than half clock hour, this is an analyst, more than half clock hour trial, so that is a different thing. More than 21 was considered, and development of acute angle closure, and of course IOP more than 30 with symptoms and signs. That is the definition that was given. And secondary outcomes are development of PACG and symptoms suggestive of raised IOP. So I'll go straight into the results here. The raw numbers were 19 treated eyes developed and versus the 36 control eyes, and that's the incidence, like 4.19 per 1,000 eye years and 7.97 per 1,000 eye years between the PI and the control eyes, double the numbers. But of course, you can see that it is less than 11 to 12% totally. To account for intra-eye, that is different. So it was significantly different, and primary outcome event occurred in both the eyes in 10 participants. That is something which we have to keep in mind. Not in the same patient, but different patients together. So this is the ZAP trial outcome, and if you notice that there were 3 out of 89 patients who developed acute primary angle closure, and that is in 3 controls and 1 LPI, I think. The one was a bilateral APAC. So 0.003% was what there, and in the Singapore analyst trial, 9.5% versus 5%, and no intervention increased the risk of progression with a hazard ratio of 2 if you don't do the LPI. majority of those who progressed developed PAC. That's something which we have to do. Both the trials had only some of them with PAS and nothing else. And APAC was 3 out of 480, so this is 0.006, double the numbers of ZAP. So that is something, again, we have to keep in mind, that the incidence of symptomatic angle closures were more in the Singapore eyes. So in the ZAP trial, they looked at the risk factors of progression. They didn't get much. So eyes with narrower angle width at baseline were one thing, but then they did a dark room provocation test and all that. They didn't show anything at all. Okay. So, but in Singapore analyst trial, we found that narrower angles at baseline, higher baseline IOP, higher post-dilation IOP, and diabetes. We included diabetes. ZAP did not include diabetes, so that is another difference. Age and male gender were another factor as well. So this 14 years outcome, I'm not sure if you can actually see it. So in the LPI group, it was 3.71%, and the control group 11.81%. But you can see that actually what they have shown as the 889 and is not there actually. The numbers are only 330 in both the groups. A lot of them had cataract surgeries and probably they removed it. They did not use an intent to treat to look at the 14 years. So obviously the hazard ratio was 0.69. LPA reduced the incidence, and so probably the NNT would have been much less at 14 years. So predictors, again, higher IOP, shallow central and limbal anterior chamber depth. So there are no more potent predictors are there. So the AUC was only 0.62 to 0.71 with those risk factors. And long-term risk and prediction of progression in primary angle closure suspect. This was actually at the time in press. Now it is published, I think. Only those eyes which with untreated PACS, they were published separately. This is 377, and 25% progress to PAC at 14 years. So in the non-LPII. So that is something which we have to think in terms of OHT kind of picture. If you see, they also had similar almost 25% progression at 20 years. So this is something probably in that context, if we take without the raise in intraocular pressure, and asymptomatic PACS may have an aggressive progression. So that is something I'm not sure if that statement is correct to make, but that is something which you have to keep in mind. But these are Chinese eyes, and they are a bit more aggressive. So that is the curve. So I will just skip these things and go to the recommendations quickly. So NNT at that time in analysis was 20.7, and ZAP was almost 56, I think. And so without the PI, patients did not progress that much. Acute angle closures were very less. Of course, the difference between the two trials I just now said, ZAP included most patients from community. They just went to the screening place and then gave the consent form and got them enrolled. While analysis was not like that. Patients from the clinic were taken, so they probably had a higher risk. So I would say that only thing which we need to think about is those who are not included in trial, we need to be careful. Vertical cup disc ratio 0.7 and post dilation IOP more than 25 and more than 8 from baseline were excluded. In ZAP trial, they removed diabetics, and family history was not considered at all. So I think those things we need to think in mind. So as of now, we should go for PI in asymptomatic PACS. Those who develop symptomatic at the end, regular dilation requirement, poor access, and I don't know about the family history of angle closure, which not answered by the trial. That goes with the consensus, I think. Thank you.